And now it's my great pleasure to introduce Dr. Leo Almeida. He's one of our own movement disorder neurologists. He came to us from Brazil. He did his fellowship at University of Florida, and he's an expert in movement disorders and deep brain stimulation. And he's going to be talking to us about current and upcoming treatments for Parkinson's disease.
All right, well, thank you for the introduction. It's been a while since I had the chance to speak at the symposium, and thanks Amanda for persisting. So I'm Leo Almeida. I'm one of the movement disorder neurologists here. And it's interesting. I was given the challenge to talk about, and there's plenty to talk about in terms of current and upcoming therapies we have for Parkinson's disease. So we're going to try to give a little overview of what we have currently available, and kind of put some sprinkles of what's been done research-wise and where we see things moving forward. Right. So first of all, we're just going to give a shout out to the team. Right. Without having such an amazing team, we can't make any of this happen. Who would imagine we'll keep our annual symposium still catching, pieces of the pandemic. So a big shout out to Dr. Malati and Amanda for pulling this off. Great job as always. And those are my disclosures, nothing pertaining to this specific talk. You'll hear quite a bit today about Parkinson's disease and some of the current therapies. So I'm planning this for the sake of time to not spend too much time here, but key points important to emphasize are Parkinson's is getting more and more common. And I think a product of that is we're living longer, right? So we have a growing population in the world, and we're surviving cardiovascular diseases and cancers and so on. So we're giving more and more of a chance for neurodegeneration to happen, right? So when you look at populational studies, epidemiological studies, and I usually tell that to the folks I see in clinic, right? If you were to get 100 random people out in the street with the trained eye, and you look very closely, you will find signs of Parkinson's or Parkinsonian signs or symptoms in one out of those 100 folks, right? If you fast forward that to folks at the age of 80, that number goes for one person with Parkinsonian signs out of 25, right? So it goes from 1% to 4%, so it's important to keep that in mind. So not only aging, but there's probably so much of a genetic predisposition and environmental exposures that kind of play a role. There have been some studies associating certain kinds of chronic exposures to solvents, certain kinds of pesticides, like there were some questions about that. Some loose associations, but that might basically set off some kind of genetic predisposition that may make things happen a little sooner than expected there. Right. And in terms of motor symptoms, or in terms of symptoms of Parkinson's in general, I often put in like in three different boxes there, if you will. So you have the classic motor symptoms, and those are kind of stuff that neurologists usually look for, right? The typical resting tremor that usually happens when you're not using your arms or legs, and that's when the tremor usually takes off. You have muscle rigidity, not necessarily a problem with the joint, but actually the muscles themselves, they feel difficult to move. And bradykinesia, which is just a fancy name for slowness of movements, right? So you may realize that things are not as fast to be done as they used to be. And also changes in posture and walking and balance and so on, like being more stooped over, shuffling, and we'll have some of our rehab colleagues talking about that later on, so won't get too much into that. Then you have another group of symptoms that we call non-motor symptoms, and that goes more along the lines of what we call autonomic dysfunction. So automatic functions of our body that we don't think about, but they're happening. So things like bladder control, GI motility, controlling of your internal thermostat, controlling blood pressure, those kinds of things. So you can also have neuropsychiatric comorbidities, so depression, anxiety, cognitive dysfunction, which is a huge spectrum that goes from just a little bit of forgetfulness here and there to confusion to dementia, and having one doesn't necessarily mean that you have the other one. Sleep disturbances, the classic dream enactment that we call fancy name, REM sleep behavior disorder. So you have different kinds of aches and pains and pain syndromes that we can see as well. And then you have another group of symptoms that are not necessarily related to limb movement, or necessarily automatic functions or cognitive functions, but so we put the other category there of difficulty swallowing, problems with drooling, changes in your handwriting, and so forth, right? So there are lots of them. And if you think about how those symptoms, the occurrence of those symptoms vary so much from one person to another person. If you were to make mathematically, if you were to make combinations of different sorts of symptoms, there are thousands and thousands and thousands of ways that patients, the symptoms can present in patients with Parkinson's, right? So it kind of goes back to when I was a fellow and we used to hear, for example, Dr. Oken saying in clinic, when you've seen one patient with Parkinson's, you've seen one patient with Parkinson's, and that's absolutely true, right? So there have the opportunity to follow siblings, and they have two completely different diseases. One person may shake more than the other and have more rigidity or less rigidity and balance problems, and maybe some of the autonomic problems and so on. So that varies significantly from person to person, right? Which actually kind of relates to this very nice figure here that came out last year in one of the papers by Dr. Armstrong, one of our faculty here in the group, that kind of talks about, kind of goes over how we should be seeing Parkinson's disease, right? So this is what's illustrated here in figure A. It's actually a drawing from 1886. And I bet you, if you were to get 100 medical students right now and ask them to put together a presentation about Parkinson's disease, at least 99 of those 100 students will have this figure here. It's most commonly seen figure there. And it looks like, this old gentleman with, stooped over, looks like moving very slowly, taking very short steps. So this is the way Parkinson's is seen at the general population. When in reality, what we see in clinic, it's a little bit different, right? So Parkinson's disease is a spectrum. So we end up catching a lot of folks in that figure, presenting as this figure B, right? And that's when we have mild, very mild symptoms, sometimes a little bit of tremor in the hand, sometimes a little bit of a foot inversion there, but they can still work and carry on with their daily activities without any interference of the symptoms or with minimal interference of symptoms. So symptoms not too bothersome. And oftentimes you will see folks who are going through this specific phase, and some of them, they may not even pay attention to the symptoms for but sometimes when you get in the history in clinic, you pick your brains, it's like, well, actually, yeah, I've had this for maybe 2 or 3 years until it became a problem. So I decided to talk about it, right? So then you go into more intermediate stages of it, and that's when the symptoms are a little more bothersome, and it starts requiring medications and medication adjustments and so on. And as the disease progresses, you can have what's called the on time and the off time. So on time when the medications are working properly, and sometimes that can come with extra movements that we call dyskinesias, and off times when the medications seem to not be working quite as well. And then you have, which don't necessarily like the word malignant, but I would say more advanced and widespread forms of Parkinson's disease, when the symptoms are more advanced, and we may need to use more assistive devices and implement other measures there. And at least for me, and I think that that might be speaking for some of the other clinicians in the group as well, is I think the big challenge is when we see folks coming at this stage, the mild to intermediate cases of Parkinson's, and when they hear the diagnosis and they come in for a second and even a third opinion, I think the biggest challenge is, to kind of get away from the stigma, the stigma of, when they hear that they have Parkinson's and they look themselves in the mirror, they see themselves like the person here on figure A, right? Which doesn't necessarily mean that this will happen in the near future, because we do know that everybody being so unique, there are completely different rates of progression, right? So some folks can get from the mild to moderate stages to the more advanced stage and more severe stages within a few years, but some of them will take decades before they get to that point, right? So everybody's unique. So that's one of the key points that we wanted to talk about. Whenever we consider treating Parkinson's disease, we have to keep in mind two things. So the first one being Parkinson's has multiple facets, right? So you have different symptom combinations, different responses to different therapies, and different rates of progression. And neurologists nowadays, particularly movement disorder neurologists, they see Parkinson's disease like many other medical conditions, right? So you can go to a pulmonologist to get your COPD addressed, or a cardiologist to get a congestive heart failure addressed. Parkinson's disease it's another chronic disease, right? So there might be some progression, there might be medication adjustments, we may need to use some therapy, and sometimes we may need surgery. So we have to take a tailored approach, for each person. So that's one of the important points. And the other key thing is, it takes a team, right? It's not just seeing a neurologist. So there is much that goes into rehabilitative strategies and different kinds of therapies, watching your diet, watching weight gain, weight loss, sometimes making sure you have all the resources that you need through social services and counseling and so on, and all the way to sometimes the need for surgical intervention to make sure we can get the symptoms under control, right? So I'm gonna go very briefly through this, and if you notice here, one of the great resources that I always recommend for patients and family members is the Parkinson Foundation, so parkinson.org. It has a very comprehensive list with very, very easy to read language in terms of benefits and side effects and everything. So, the principle is rather simple. So you have deficiency of dopamine in the brain, that's easy. Let's replace that dopamine, right? So there are different forms of levodopa, just to give some examples there. So it comes in tablets, capsules. Most recently, there is an inhaled form of it. And then there is an intestinal gel pump. Not everything is related, it's treated with levodopa. And we'll talk a little bit more about that coming up in a few slides. But you also have a group of medications. They're not dopamine per se, but they act in the same receptors, right? And there are different formulations of it. And I really don't feel like spending a whole lot of time on this will be interesting, because everything we take that on a case-by-case basis. There are other classes of medicines that we use, the monoamine oxidase B inhibitors and the COMT inhibitors, and I put a little asterisk here because those are kind of newer drugs in the past few years, and this one is fresh off, into the market over the past few months. And then you have some older medicines that we use in specific scenarios, such as stubborn tremors sometimes, or to manage what we call dyskinesia, those excessive movements. And this is a new class of medicines a new class of medicine that just got approved for Parkinson's. And how do we make sense of all that, right? So you can basically break those medicines and put them into specific categories, right? So we have a group of medicines that were responsible for what we call dopamine replacement, right? So putting that dopamine that is deficient back into the system in the form of levodopa or the agonists, right? And then you have another group that I usually call the dopamine boosts, right? So they basically get whatever dopamine is lingering in the brain, and they try to enhance its effects or kind of make it stick around a little bit longer to prevent degradation of that dopamine that is there, right? So they're usually used as an add-on therapy to the levodopa. And with the exception of the MAOBs, sometimes when you see folks in the very early stages of the disease, you can prescribe this as monotherapy. But more and more, we are seeing those being used just more as a boost. So usually when patients get into the stages where they have wearing off, and off and on times, that's when we start using those medicines to try to bridge those gaps a little bit better, right? And then like I mentioned before, anticholinergics are used in scenarios, very restricted scenarios that you have very severe tremors there that the levodopa doesn't seem to be capturing, and amantadine is mostly used for management of dyskinesias. So, all right, so yeah, so it's just to, as an overall rule of thumb, right? So neurologists usually prescribe some kind of a dopamine replacement, right? And then you will see boosts being used when there are gaps in between the benefits from the doses, right? With the exception of the MAOB inhibitors that we talked about already. It's important to keep in mind that there will be certain stages for different folks that we may need to combine therapies, right? We talk about in clinic, but the so popular honeymoon period when, you know, folks get the onset of the motor symptoms and they get the diagnosis and they tend to do very well with teeny tiny bits of medications there, not a whole lot of adjustments, but that is a given stage, and that varies also a little bit from person to person, that we'll start seeing more and more disease progression, and we will have to make some adjustments to compensate for that, right? And usually when we talk about disease progression, the manifestations of that are basically three main ones. So you either have worsening of motor symptoms. So let's say, you know, you had your typical tremor, slowness, stiffness, and the certain amount of medicine used to control them really well. A few years go by, and it seems like that same dose that we used to use from the past few years is not controlling, it doesn't kick in as much, you know, like we usually say. And then we end up raising up the dose, right? Or it can manifest as motor fluctuations, which essentially means it still works really well, controls the symptoms really well, it just doesn't last long enough, right? Or it can present in the form of what we call dyskinesias, which are those dance-like wiggly movements that are involuntary, and that's usually in the context of being a little bit on too much medication. Sometimes it comes as the medication levels are kind of tapering off, so it's taken on a case-by-case basis, right? So this is a busy slide, and I'm glad this is going online, so you can always go back there and kind of read that in more details. But the key concept about motor fluctuations comes because of two main factors, right? So the first one is dopaminergic therapies, particularly levodopa, they have a very short, what we call half-life. So it doesn't take very long for like half of that drug level that is circulating in your blood to come off of your system, right? So, so if you get a condition that the strongest treatment that is available, even though it's very effective, but doesn't last very long because it's a very unstable molecule. If you combine that with the fact that there is a progressive neurodegenerative process, which means those cells, they're becoming weaker and weaker and degenerating more and more as time goes on, right? So the key point here is it's not necessarily that your brain got used to the medication, or it's not because you're resistant to the medication. It's more there's a degenerative process and there is less dopamine in that system. And as a result of that, we have to increase the amount of medicine to kind of pick up that slack, so to speak, right? So, and this is an important concept to internalize, because sometimes we even see general practitioners out there in the community, you know, and we get stories of patients who would come in to see us, and they're clearly having issues with symptoms getting in the way of their quality of life. And they, you know, and they may report, well, but my local doctor said that I shouldn't be on medication to save that up for the future, right? So that isn't such a thing, right? So it's more like it's actually more of the opposite. So the disease progresses to the point that we may need more medicine to get the symptoms under control, right? Again, circling back to that slide, it takes a team, because the reason for that is not everything responds to levodopa. And I think that was actually one of the questions that we had in the chat for Dr. Pukowitz. There are symptoms, there are what we call refractory to medical management. So then being on the appropriate exercise program and seeing the appropriate therapist who's skilled in recognizing and addressing that properly is the way to go. there are situations that maybe considering a surgical intervention might be the way to go. So it's tailored to the patient, right? So, and that's what this slide is talking about. So when overall management is not enough, there are more invasive therapies. So we can potentially convert the majority of that oral medication that you're taking and convert that into an intestinal gel pump. So levodopa comes in a gel form. That is a small surgical procedure that needs to be done with placement of what we call a J tube, which goes straight into the jejunum, and that gets connected to a pump that is a little bigger than if you've ever seen an insulin pump. And there are gel cartridges that are inserted into the pump to every little while, little drops of that gel are being released and straight into the gut wall. And that's important because it bypasses the whole business of you having to swallow a pill, getting the pill to dissolve and be absorbed. So it keeps the levels as constant as, as it can be. And then surgical therapies, right? So we have deep brain stimulation, which involves the implantation of electrodes deep in the brain, connected to a little pacemaker-like device that we can control certain symptoms there. We'll talk a little bit more about that coming up. Focus ultrasound, which doesn't necessarily have any implants, but it does involve creating a lesion using very strong ultrasound pulses. And the principle is there is a dysfunctional network and you hit one of those targets, one of those cogwheels there, that part of that circuitry, and you cause a disruption in disrupted network, and you kind of reset things back to how they should be. We don't do those procedures here, so not very familiar with the ins and outs of what the procedure looks like, but the base principle it's that. But that's great, Dr. Almeida, but that's not what we're here to listen to. So what's new? And we usually get that question in clinic, right? So what's sometimes we see patients twice a year or just once a year. When they come in, they want to see what's new, what's up and coming in the field, what's down the pipeline. So a few resources, they're very important. I stole this slide from Matt Burns. I think he gave this presentation not too long ago. So clinicaltrials.gov is it's from the government. It's associated with the National Institutes of Health. And it's actually a requirement. Any serious clinical trial that is out there recruiting patients and that wants to be published in a respectable journal, every single one of those clinical trials, every single one of those studies is listed in clinicaltrials.gov, right? So, and it's just a little cliche there, but every single talk that we go talk about PubMed or any of those big databases, the presenter always does this. So I thought I would do that too. So, as of yesterday, if you search for Parkinson's disease, there were 663 results being tested registering Parkinson on clinicaltrials.gov. That was worldwide, right? Not necessarily they were all drug trials. Some of them are looking for biomarkers, testing new modalities of scans and so on. Spin-off information sources that you can get are PD trial tracker info, which basically it's a compilation of what's available here on clinicaltrials.org, but they kind of break it down really nicely for folks to just kind of search specifically for what's going on in Parkinson's disease, because clinicaltrials.gov can be a little clunky to click around and get the results that you're looking for. And Science of Parkinson's is another good resource, more like a blog. And this person has a PhD in neurobiology. He's worked with a bunch of clinical trials of Parkinson's disease. He basically breaks it down into a language that folks who are not very familiar with research can understand. Right? It's also important to keep in mind there are different phases of clinical trial. And as we're talking about some of those, you will see me saying, well, this is a phase 1 clinical trial, phase 2, phase 3, phase 4, right? And a very simplistic way I tell patients is that, so phase 1 is when it first gets moved from animal studies into humans, right? Even though it did very well in mice or monkeys or so on, when you transfer that to humans, you have to test for safety, right? I usually joke to make sure we're not going to turn into the Incredible Hulk. So we do a very small study and a small number of patients to make sure it's okay. And then you move from a phase 1 for phase 2 trial, which we know it's safe, but now let's test out different doses to see, is there a specific threshold? If you cross that dose, does that start giving any specific set of side effects, or do we see any specific benefit, right? So everybody's tested different doses and we see what happens. And then when you go to phase 3, that's like, well, we've tested, we checked for blood levels, we tested for side effects, we tested for benefit. Now is the time to test for efficacy, right? So once we get to a phase 3 trial, that's when you will see drugs or interventions being tested against placebo, for example, right? So to see how efficacious that intervention will be. And once we have passed that phase 3, that's when everything goes for the FDA to be reviewed. And you know, if it's a promising, a good therapy that's going to benefit individuals with a certain condition, that's it gets approved. And you will see several of those studies going to what's called phase 4 trial, which is a post-market study. So they put the medication back, they put the medication in the market, but they will keep track of folks who go on that, and they create registries and track for maybe new side effects that didn't occur during the other stages of the clinical trial, right? So it's important to keep those phases in mind there. This is also a busy slide, but that goes to show that the degenerative process that happens in the brain with folks with Parkinson's, it follows stages, right? So there are those two pathologists close to 20 years ago. They published the deposition of those proteins in the brain, right, in the form of Lewy bodies. So, and you have, it starts in a specific, or if you think about the brain like a little mushroom that sits in the stem, so it starts in the brain stem and kind of moves upwards, and then it spreads to other areas of the brain, right? So, and it's not until it reaches a certain point, you know, in that evolution process there, that it starts creating what the typical symptoms that we see, right? So you will hear us talking about in clinic about what we call the premotor symptoms, you know, so symptoms that happen before the tremor, slowness, stiffness, and postural changes, and so on, right? And this is just to show that if you consider the motor onset as your time 0, some of those symptoms, they can precede the onset of the motor symptoms by, you know, over a decade, right? So then I think one of the biggest challenges when it comes to developing new drugs for Parkinson's, especially if we're looking for agents that will slow down or reverse the disease, we want to catch at this stage, right? Because once we get here, there is already a big chunk of neurodegeneration that has happened. So this basically shows just what we talked about. Each one of those stages has specific limitations there that they're important to keep in mind when we're designing drug trials, right? This is just another slide that just shows how things spread out, right? Starting from at the bottom of your brainstem and spreading to other areas of the brain, right? And this is the alpha-synuclein, is this misfolded protein that tends to deposit in the form of Lewy bodies, right? And so we know some of the pathological findings. We see this when you look at this is exactly what it looks like when you look at the brain under the microscope. So we see this, oh, okay, so this is consistent with Parkinson's disease, right? So if we do that, it's, the next step is, well, can we come up with a drug that prevents that from depositing in the brain? Or, can we come up even with a vaccine that can potentially eat up that protein and just degrade the protein and just, get rid of it. So maybe if it doesn't deposit, we won't have symptoms, we won't have progression and so on. And I'll tell you that this is what many studies are looking for right now. So you may recognize some of those slides that have been presented before, but we did a little bit of update based on clinicaltrials.org. I will say, and all the research coordinators that are listening to this talk right now, they're probably nodding their heads, yes. 2020 was a tough year for clinical trials. We had lots of issues with COVID and so on, because it affected recruitment and seeing those patients for visits. So some of those studies they haven't had a whole lot of updates. But again, so just considering antibodies against alpha-synuclein, right? So this is a phase 2, right? So no Incredible Hulk, but we don't know the dose yet. So we don't know if that is a dose that's going to be beneficial, right? So there are basically 2 studies looking at that. So last year, there was only the Pasadena study. That was looking for folks at the early stages of Parkinson's, early stages of the motor symptoms of Parkinson's, not on levodopa. So they already closed enrollment. They have some preliminary results. They were posted on clinicaltrials.org, which I can't comment on too much because the breakdown of the results, it's not very clear, but essentially they tested placebo, low dose, high dose. And the interesting thing is, and I think that's why, that isn't much on this yet. It's just looking at the gross numbers there. We don't want to make any assumptions based on that. But seems like the high dose, was pretty comparable to placebo, but there were differences between placebo and the low dose, and difference between the low dose and the high dose in terms of some improvements in some of the things that we have folks do in clinic, like tapping the fingers, opening and closing, and so on. So there's probably a lot more to that the folks who are conducting the trial are going to have to kind of break that down and put it together in the form of a paper. So there's more to come on that, right? But then they start looking, but they probably saw something that looked promising because as of last month, they started a trial, still phase 2, still the same drug, on folks who are on levodopa, right? So this is called a PADOPA trial. So there's more to come on that. There's another one testing a different molecule. It's called the SPARK trial. It's also another phase 2, trying to figure out blood levels and levels that will give doses that will give side effects and so on. It hasn't completed yet, so we don't really have any preliminary results. Another one, there's a phase 1. So this one's just got transitioned from the animal models into humans, and it apparently just, it was expected to be completed earlier this month, but we don't have any results publicly available yet on clinicaltrials.gov. So and that was the one testing in healthy individuals, not even individuals with Parkinson's, but they also had a different arm of the study, well, a different study testing the exact same compound in patients with Parkinson's disease. And that's to be completed next year, right? So this is another compound by a company called AbbVie, and we were actually one of the sites for this. It's a phase 1, right? And currently it's withdrawn from recruitment, and can't really comment a whole lot on the reasons why, but it's publicly available. It's in strategic consideration, so it's something probably related to the logistics of recruitment. Like I said, last year was a tough year. So all those studies are multicentric, So and UF was actually one of those sites. So so there's probably, so it was scheduled to, I don't know why the slides are advancing automatically, yeah, so this is scheduled to finish this year, but there's probably some pullback here on when we're going to have some results. I guess some of the aspects of the study, they went back to the drawing board in terms of recruitment of patients. This is a new one that's it's been there since this talk was given last year, right? And that's another one to inhibit aggregation of, that mutated protein, the alpha-synuclein in the brain. This is a British study. It's being conducted at 2 centers right now, and it's assessing basically blood levels and food interactions at this point. So it's still like within that stage 1, stage 2, phase 1, phase 2, right? And then oh my goodness. And then we have the other compound that's being tested right now at the Netherlands. And again, this is a phase 1 trial, right? So it's just transitioned from the animal models to human testing. It's expected to be completed next year. And this is actually an alpha-synuclein vaccine, right? So it's kind of teaching our immune system how to recognize the alpha-synuclein and try to go in and eat those proteins and get rid of it, so to prevent the disease from progressing. So there's more to come on that, right? And then the other aspect to that is, so we know about alpha-synuclein and Lewy bodies and so on, But what about, what if this is just a final product of something else, right? What if the answer is on the genetic background? So that's another portion that the field has tackled quite a bit. So just one of many genes that we have there, it's LRRK2, right? LRRK2 is seen about 4% of the Parkinson's disease diagnosis there. And it can be in familial forms, it can be in sporadic forms. And basically that is this specific enzyme there, LRRK2, that seems to be overactive in folks who have that mutation. And that starts leading to the production of alpha-synuclein and Lewy bodies, and relates to the speeding up of neurodegeneration there, right? So, but I think it's an interesting concept, because if they develop a drug, is that a drug that is only going to benefit 4% of the folks with Parkinson's? Not necessarily, because it may be that even though you may not have a mutation on the LRRK2, you still may have an overactive function of that specific enzyme. So you may still benefit from it, right? Because there have been several testing in animal models that shows that we can potentially lead to neuroprotection, right? So it's important to consider that. So just kind of going over, so this basically has been presented before, and there hasn't been a whole lot in terms of updates here, and I think mostly goes to show how tough recruitment was last year. So we don't have, so even though this was suspected to complete enrollment last year, we don't have any results yet, but those are compounds, they're targeting, inhibiting that specific protein LRRK2. Right, so there are basically two that are being looked at right now, and this one is still ongoing. Again, many of those are multicentric studies. There are multiple centers recruiting patients across the globe. This one is expected to finish in a couple of years, right? And then the way I see it is, if you think of one specific gene as just one of the cogwheels, part of a big machine, right? So I think the way to go about that is understanding what each one of those genes actually does inside of the neurons can actually point towards multiple different paths that we can potentially intervene with certain drugs to improve symptoms, right? And either improve symptoms or slow down progression. So depending on what function that specific enzyme has, in the cascade of things that happen in folks who have Parkinson's disease, right? So there are a number of different genes out there, and there is really not much time to actually go into that, but there have been several clinical trials targeting, different different genes and different enzymes, within the neurons. Right, and then and I'll make the same analogy to LRRK2. So even though you may not have that specific mutation, that little enzyme there might be dysfunctional in your case. And so maybe the way to go a few years from now, once we have that technology available, would be to not necessarily test for the gene, but basically test for an enzymatic function, and say, well, it maybe you was, instead of saying, well, you have a tremor form of Parkinson's disease, or you have a rigid form of Parkinson's disease, maybe you will be, well, you have a dysfunction of X, Y, Z enzymes, and maybe you benefit better from those specific treatments to prevent things from getting worse, right? But this is just like part of the vision that the field is going. If you have the mutation, it's great, but if you don't have and you still have a dysfunction, you may still benefit from it, because the therapy is actually targeting to inhibition of the enzymatic function. And this is just like the big picture, and this kind of gives me like PTSD from medical school. It always makes me feel kind of stupid, because I feel like, well, I can't memorize all this, but so it's one of those pictures that everyone loves to hate and some folks hate to love, but it kind of goes to show how complex the machinery is inside of a neuron, right? And then you have different molecules that have been tested, different drugs that have been tested, and you can see each one of those is targeting different pieces of the puzzle, right? So, which actually goes to show how complicated it is to recruit patients to recruit subjects for a clinical trial, right? So you may or may not remember if you were at this symposium last year with Dr. Alberto Espe, right? So I agree 100% with that concept that there are multiple manifestations of Parkinson's within the diagnosis of Parkinson's. And I think you might actually come down to how those cells function, and we don't have a way to test for it quite yet. And I think responses to medicine, so it may be that sometimes a negative trial, let's say a trial that doesn't show a positive result, it may be because we recruited patients that maybe were malfunctioning somewhere around here, and we gave a drug that acts more like here. So, it may have helped like a handful of patients, but not everybody. So I think once we get technology available to be able to test, if that comes up down the road, I think we'll be able to tailor who to recruit for clinical trials, more accurately. Right, and we'll be able to test efficacy of those drugs a little bit better. So we may end up going back to the drawing board and retesting some drugs that have been tested negative, right? Which kind of goes to the concept of personalized medicine, right? So we try to get one drug, one treatment that fits everybody, but we've learned, we've seen more and more that personalized medicine is the way to go, because there are no two diseases alike, there are no two presentations alike, and that's more than true for Parkinson's disease, right? So everybody's very unique. So we have to address not Parkinson's need, but your Parkinson's needs, right? So the vision will be potentially like a treatment cocktail, right? So you have maybe preventing protein aggregation, some kind of vaccine, which should be given ideally for folks before they have any symptoms, right? So you have to identify who are the potential folks at risk of developing Parkinson's disease 20 years from now. So you can see how big of a challenge that will be, right? And then for folks who have like mild to moderate symptoms there, they are a few years or maybe even over a decade into the degenerative process. So maybe the cocktail will be a little bit different. So we'll have to focus more on stopping the progression by blocking certain portions of the dysfunctional neurons. And potentially, if there is a treatment that is available to promote regeneration of those neurons, maybe make some of those cells work better and some of them to grow back. So there are lots of opportunities for research. There are being explored, but they're not quite ready for prime time yet, right? And then for folks who are a little more advanced, still it's the same principle. We stop any potential progression that there might be, and basically focusing the cocktail on some potential regeneration that may happen, right? But that's the ideal world. That's the vision that the field has. But until we find the cure, we still have to manage symptoms, right? So where are we on that? So just in considering what the ideal drug would be, so we still don't have silver bullet for Parkinson's quite yet. We're still stuck with pills, taking multiple times a day, and we talked about half-life and how that plays a role into all that. Ideally, yes, we should have one pill a day that, so you don't have to take multiple doses with very low side effect interaction profile. So we're not quite there yet, right? And then we have the two main factors that complicate Parkinson's management, which are motor fluctuations, which we talked about, the off and on times, and then dyskinesia. So what do we have new here? So things that have come to the market in the past year. So we have Inbrija, which is an inhaled form of levodopa, which basically is almost like an asthma pump. And the absorption is a lot quicker than having to swallow a pill, wait for it to dissolve and to kick in, and folks with Parkinson's will say, well, it takes anywhere between 15 minutes and 45 minutes, sometimes a little less, sometimes a little longer than that for each one of my doses to kick in. And this one basically reaches blood levels in 5 minutes, and it reaches the maximum blood level within 15 minutes. Doesn't substitute our medicines. It's used as an add-on. So let's say, if you're having off times and on times, during the off times, that can be a strategy to kind of jumpstart the system, so to speak. Kenmobi, it's the same apomorphine that we have in the market now for a number of years. which Apokyn is almost like a little EpiPen that you inject to kind of give that jump start during the off times. So now is available as a film, almost like a little piece of gum that you put under the tongue. Used as rescue therapy. And then Ongentys is one of those COMT inhibitors, one of those boosts that can be used to boost dopamine levels. So it's used as an add-on therapy to levodopa, right? One of the new ones that I came across in clinical trials, the clinical trials portal, is tavapadon. There's a TEMPO-3 trial, which is a new agonist. So it's another one of the dopamine inputs, a type of medicine that will fall in the first column that we showed a few slides ago. It is in phase 3, being tested, head-to-head against placebo. It's expected to end next year. So we'll have to see. It's a little more selective, so that might be a little bit better in terms of management of side effect profiles and, potentially. So we'll have to wait to see results in dosages and what's been tested so far. So there's more to come on that. So hopefully next year or a couple of years from now, we'll be learning more about this drug. Right? And then we have the continuous infusion therapies, which basically what we've had until now, just the infusion gel, the Duopa. We have a few number of individuals here in the clinic that we follow for that. That kind of replaces what you take by mouth, and little by little kind of delivers some straight into the gut wall, right? In the near future, well, actually right now it's in phase 3 clinical trials. We're testing 2 liquid forms of levodopa connected just like an insulin pump. So it's a subcutaneous access, so it doesn't require placement of a feeding tube. So it's constant delivery. So there are 2 competing companies. One is called Neuroderm and the other one is called AbbVie. Interestingly, University of Florida is a recruitment site for both of them. So it's still in the phase of recruiting patients, but it's phase 3 trial. So it's actually looking for the efficacy portion. If that pans out to be something that is viable, that's next stage will be FDA approval, so we can offer to our patients. So there will be more to come on that, definitely, in the near future. And this one I also came across on Clinical Trials Portal, which is it's an oral levodopa delivery system. So it's like a dental retainer with with a little small pre-filled container of carbidopa levodopa that's going to be like releasing little drops of carbidopa levodopa in a liquid form, every few seconds. So it is in phase 2 trial. So they're trying to figure out, if the levels in the blood can be constant there to be monitored. So there's more to come on that, right? Might be another way to deliver medication in a constant basis without having to worry too much about, taking several pills multiple times a day. This one is kind of like a new therapy, mostly in the United States. It's been used already in other countries, but here in the US, it's phase 3 trial. The same drug that comes in an injectable form or the sublingual film, it has a liquid form that connects to a pump-like device. It's just like an insulin pump that is subcutaneous access that you change, often to kind of rotate around. It's the exact same drug, but it's a constant delivery instead of you having to take as needed. So this can be, potentially a replacement for some of the pill burden, so some of the number of pills that you take on a daily basis. So there's more to come on that. We know it works in other countries by talking to folks from outside the US, but it's currently being tested in the US to kind of go through all the hoops with the FDA to get approved. And then, a topic that I always enjoy talking about, but it might be something to talk for another 4 or 5 hours at least, which is deep brain stimulation, which is running out of time here, but very effective for managing motor fluctuations, dyskinesias, and refractory tremors. And it's important to keep in mind that just similarly to levodopa, it does not improve everything. So it doesn't help with non-motor features, depression, anxiety, cognitive dysfunction, drooling, and so on. symptoms also that do not respond to levodopa, with the exception of refractory tremor, may not respond to deep brain stimulation, right? So I just want to take 3 or 4 more slides to talk about, there are 3 different brand manufacturers in the market, so Boston Scientific, Abbott, and Medtronic. And what's new in the past year about them? So first of all, DBS and MRI compatibility used to be an issue before, because we used to prefer one versus another because some of them were not MRI compatible. They all went through all the safety protocols with the FDA, and the long story short, they're all MRI compatible right now. And this is a potential game changer here for a select number of folks who undergo deep brain stimulation. Abbott was the first one in that race to get clearance from the FDA to have telehealth programming. So yes, clinicians, and this was just a press release from literally last month. Clinicians will be able to program those devices with the patient at home. You know, and of course, in situations like the pandemic, there will be something that will be very interesting, right? Because we keep the patient in the safe environment, and we can do most of the programming there. Now, I haven't got my hands on those programmers yet, so I can't really comment on the ins and outs and so on. But it's been used in other countries. You know, it's just been more like a cybersecurity issue in the United States. So Boston Scientific has something called HeartConnect, which is kind of like something in between. You can't really program the devices, but you can connect a DBS expert to maybe the primary care doctor's office. And if they're holding a clinician programmer, that they can make the adjustments. You can visualize their screen and kind of guide them through where to click, what to do. You know, so that might be an option to consider for folks who are several hours away or out of state or even out of country. So it's a little bit easier, but it's actually basically a Zoom platform that we can see the screen on the other side. But I think the most one of the most exciting things that we've had happening in the past year is the advent of Percept from Medtronic, which basically is a technology that it's been investigational for the past 10, 15 years, kind of trying to listen and learn from the brain cells, from the actual potentials, and see how those cells behave. And based off of that, we learn more about the disease. You know, so what do the brain signals look like when you take levodopa, when the medication wears off, when we implement stimulation? So what happens with that, right? So then now this is commercially available for folks who have deep brain stimulation from Medtronic. And I think it's just a matter of time before the other companies pick up the pace on that specific feature, right? But that kind of brings to one very exciting clinical trial that we have right now, because the way we think about DBS is you put your settings there, and it's a set and forget, you know, like a slow cooker kind of thing, you know, so the device stays on all the time, and you don't worry about changing anything unless that is like a specific side effect or something like that. Now, with the capability of sensing and listening to the brain cells real time, we can actually train the machine, and that device actually allows us to, if you are in a state that medication is on and you don't need that much stimulation, we will know about that based on your brainwave activity. It ramps the device down, so it saves battery time and potentially avoids side effects. For example, having the stimulation and the medications at the same time can lead to dyskinesias. So there are lots of things that we can potentially alleviate with that. But there's more to come on that. So we've known that some of those algorithms have been tested. You know, some of the big centers in Europe, Dr. Helen Bronte-Stewart, you know, folks from Stanford here in California have been doing this for 10 plus years. Us here at University of Florida, we've been doing that, not necessarily with Parkinson's only, but with other neurological conditions as well. But this is the first commercially available industry-sponsored clinical trial to test one of those algorithms in patients with Parkinson's. It's testing it's recruiting patients across 12 sites in the world, Europe, United States, and Canada. And we've been very fortunate to be one of the sites for testing, and hopefully we'll have a first recruitment very, very soon, right? And I believe this is the last slide, you know, so DBS research, yes, we do lots of it here. And where things are going, it's not necessarily just the automated process of delivering stimulation to the brain, but also come up with pulses that are more efficient than what we have commercially available now, understanding pathological brain signals and come up with connections between different areas of the brain and understand how the disease works a little bit better. And of course, every time you hear about University of Florida and deep brain stimulation, you will automatically relate back to those guys, Dr. Oak and Dr. Foote. They've been doing this for the past 20 years, but I think more important than that, than what they contributed to the field, is their legacy by inspiring the next generation of researchers here that are going to bring deep brain stimulation to the next level. And I've been very fortunate to have the opportunity to work with some of them. So it's a shout out to the folks part of our brain mapping lab. You know, they're on the forefront of the cutting edge research in deep brain stimulation in the world, that's for sure. So if you're interested in clinical trials and research for Parkinson's disease, I think a great resource is the Michael J. Fox Foundation Clinical Trial Finder. And that's the address. If you Google Michael J. Fox Foundation Trial Finder, it will take you to this link. And it literally starts with questions. Where do you live? Are you looking for this? How long have you had the disease for? And it will give you a list of which clinical trials are the closest to you. Parkinson Foundation also has a program, the Research Advocates. And those are individuals with Parkinson's disease and their care partners. They apply to be advocates, and they are going to be that link between their support groups and, you know, the researchers that are working with Parkinson's research, right? If you want to know more about what research projects we have going on at University of Florida, you can talk to one of your doctors if you see one of the doctors here. If you have any specific questions about a specific trial, so you can talk to Julie Segura. She's our big boss, clinical trials. And I think that's all I had. That's my contact information.